All right. All right. Well, welcome everybody. Welcome to I think this will be the fall version of the Trauma Nursing Journal Club. We have a good group of emergency and trauma nurses on tonight. And why not? We have absolutely got a superstar in the world of disaster nursing that I'll introduce you to very, very shortly. And I can't tell you how thrilled I am to have her here tonight. It's a topic that has been near and dear to my heart. I've dabbled in the world of disaster nursing and emergency management for many years. Obviously, yes, my true love is trauma, but I do have these peripheral loves, and emergency preparedness and disaster is one of them. So when I saw this article written by Jamla, I said, okay, I gotta see if she'll come on the Trauma Nursing Journal Club and kind of soothe my needs for a little bit of a re-energization of my inner trauma, my inner disaster nurse. And also, let's see who else out there would be maybe looking at it, has dabbled in disaster care, will be willing to kind of, put their accolades out as Jamla discusses her article tonight. So again, thank you all for being here. Again, we are being recorded, and this will get posted on YouTube. Once that posting gets done and I get it rendered, I'll send everybody a link to it. And if you like the content tonight, and I pretty much guarantee you will, send that oh my goodness, link on to anyone else who you think might be interested in what we're talking about tonight. Oh, already said that. See, I'm already a slide ahead of myself. Okay. For those of you that have never been involved with the Trauma Nursing Journal Club, this is part of a continuum of education that I do. I am the Trauma Geek, and you can find me on YouTube under the name of the Trauma Geek. So there are a number of other videos that are up there from some other companion talks that we give, as well as other journal clubs that we've done over the years. So please, take an opportunity, go up there. Most of them are centered in obviously trauma care, and I do a tremendous amount of work in the pre-hospital environment. So there's a lot of pre-hospital related stuff up there. And I'm proud tonight, or after tonight into tomorrow, getting disaster up there. So, and there's a little disaster up there to begin with, but this will help complement what's already up there. So, for those of you that don't know me, my name is Steve Wyman, and I am with the trauma program at St. Joseph's University Medical Center in Paterson, New Jersey. We are a regional trauma center serving the northern portion of New Jersey, along with some sister trauma centers up here. And then I'm absolutely thrilled beyond speech that we've got Jamla Rizek here tonight, and I'll give you a little bit of an introduction to her very shortly, and let her kind of introduce herself after I give her a good introduction. But from the standpoint of disclosures, we do not have anything to disclose. And certainly from my vantage point, and I'll let Jamla speak on her own, the comments and the views that are expressed tonight are those of myself and probably Jamla as well, but I'll let her speak on her own behalf. And they do not reflect the opinion of any of our associated agencies, organizations, our employers. But speaking strictly for myself, they absolutely should. So, Jamla, you have a disclosure.
I do. So thank you very much, Steve. I am an active duty nurse officer, so I do work for the U.S. government. So I am here representing myself, representing Adventures with Nurse Jamla. So everything you see from me tonight, everything I say to you is representing myself, does not represent the government in any way, shape, or form. So I just want everybody to know that that is a disclaimer. I will be sharing some information on ways to get involved, and one of them will be, as Steve mentioned, in regard to the paper, which we'll talk about. But there's another way to get involved in regard to disaster preparedness, disaster response with the federal government. But again, I am not endorsing it. It's just another opportunity to share for those of you that may be interested. Other than that, I have no other disclosures to share.
Beautiful. So there is continuing education credit available tonight only for those of us that are on the live portion. So if you are watching this right now on YouTube, sorry you missed your opportunity, but I guarantee you the content is going to be stellar. There's no doubt about it. So to get this out of the way, tonight the continuing education is provided by the Institute for Medical and Nursing Education, and they are accredited provider of nursing continuing professional development by ANCC's Commission on Accreditation. Right now, we're scheduled to give you about an hour of credit for your time. If we get some really good conversation going and we go over an hour, then I will adjust the amount of credit accordingly in quarter of an hour increments. This has an old date on it. Don't worry about the date that's on it. I forgot to update that. I'm a believer that you cannot have perfect slides, by the way. It's bad luck. So there's my error for the night. But like I said, the information here will be great, but the credit, unfortunately, will be for the live participants only. Sorry. This is part of a trauma nursing education continuum that I do. I do obviously tonight the Trauma Nursing Journal Club, and I'll talk to you a little bit about what that entails. But I also do another companion series called Topics in Trauma Nursing, and on a quarterly basis, I try to find either myself or I try to find somebody who can talk about a really interesting, hot, or controversial topic in trauma care, and then present it and do it in a nice lecture, kind of interactive lecture series. So some of you, I think most of you that I'm looking tonight that are on have been part of this in the past, so you kind of know a little bit about what it's about. But again, you'll find all of these things posted up on my YouTube channel under the Trauma Geek. And speaking of topics in trauma nursing, if you are so interested, here's our QR code. You can zap real quick. The next topics in trauma nursing will be December 17th at 8 p.m. It's going to be a case of parkour induced trauma. WTF is parkour, okay? I'm not going to let it go any more than that. If you know what parkour is, you're ahead of the curve. If you've never heard of it, then you certainly can look it up between now and December 17th. But it's an interesting case, and this is a reprise of a lecture that I gave at New Jersey ENA's Emergency Care Conference last year in Atlantic City. So I think you'll find it very interesting, especially if you've never heard of parkour and you don't know what it is. It was a surprise to us when we found out what this is with a patient in our trauma bay about a year and a half ago. And I'll put that up again at the end. If you didn't get the QR code, I'll pop it up there for you. And again, as Jamla said, and you can see, she is dressed in her ENA purple tonight. So first of all, happy Emergency Nursing Week to everybody. But more ardently, and I had no idea when I picked tonight's date that this would be the case, but today is Emergency Nurses Day. So welcome everybody. Congratulations. We are absolutely the unsung heroes of healthcare. And you know what? I think we're getting out there. I think we're more being the sung heroes. And I saw this right before I popped on. Anyone who knows me knows that I'm an absolute nut for the pit. So I will pop Noah Wiley's post that came out tonight, wishing everybody a happy Emergency Nurses Day. So if Noah says it's true, I'm going to believe it too. So again, thank you all for being here tonight. And again, happy Emergency Nurses Day to everybody. All right, so the rules of Journal Club, just like the rules of Fight Club, okay? Basically, the purpose of Journal Club, and the reason I put it together, is I noticed that as clinical nurses, we shied away from looking at the literature critically, okay? Journal of Emergency Nursing comes out, and yes, sometimes it's very heavy with research articles. These are excellent research articles, but sometimes we either skim over them or don't read them at all because we either think we don't understand them or we don't want to tax our brain in understanding them. So the real goal of the Journal Club in its infancy was really just the ability to bring people together, talk about these articles, and demask the mysticism behind a research article. Talk a little bit about what they mean, how you can interpret them, and how you can use them and additional literature to change or frame your practice. And that's really what Journal Club is all about. Some articles are very science and very, very, very data laden. Tonight, we're presenting an article that's not so data laden. So I try to kind of get an admix there. Okay. At the end of the day, we always want anyone who attends any of the Trauma Geek type stuff to walk away from the session feeling a little bit more informed than when they started. And who knows, maybe tonight we'll send you on the trajectory of a new career path. You just never know. And we have to give a shout out to our journal, the Journal of Emergency Nursing. Both myself, Jamla, Joe Blansfield, who's on the call tonight, are all part of the editorial staff of the Journal of Emergency Nursing. Joe and Jamla both are part of the executive editorial group within the journal, but Jamla and I also are section editors, with Jamla going over, I guess you'll never guess what Jamla does in the journal, but she's the disaster section editor, and then I am the trauma section editor. So we've got a phenomenal journal with the Journal of Emergency Nursing. If you are an ENA member, then you get this as a bonus to your membership. If you are on this call tonight and you are not a member, the only thing I can say is why. You should be. So hopefully you go and you join. All right. But this is a great journal. The journal is extraordinarily user-friendly when it comes to taking new nurses who want to publish for their first time setting you up with almost like a mentorship, if you would like it, and helping guide you to publishing your first paper. There are very few journals out there that do this. And again, Jen does this under the leadership of this lady in pink in the middle, Anna Valdez, who absolutely is the cream of the crop when it comes to being not only editor in chief, but also just a great all around individual. So if you are interested, www.genonline.org will get you to the website, and everything there you need to know. And again, you can reach out to me, you can reach out to Jamla. We'll be happy to chat with you and try to recruit you in to write an article with us. And then there is Jamla, the social media superstar. So in the chat box, I have put a link to her great social media, and just go up there. It's phenomenal stuff. She's absolutely doing what I love, and I think this will be my next foray into social media. We'll be going to TikTok. My biggest problem is I can do nothing in like 30 to 90 seconds. I'm lucky if I can give a talk in 30 minutes or less. So I'm not sure how TikTok will work for me. It'll be me being cut off half sentence, I'm sure. But absolutely go up there. She has done some phenomenal stuff. And since we just left September, which was Emergency Preparedness Month here in the United States, she, on a day-to-day basis, went through kind of a pearl of wisdom for emergency management and emergency preparedness. So I wholeheartedly urge you to go up there, subscribe, and hang with Jamla on her TikTok and her blog. All right, so let's talk a little bit about Dr. Rizek. I got to tell you, again, thrilled to have you here. So trying to prepare a summary about you was extraordinarily difficult. Okay. Fortunately, we have AI, and fortunately, I did find a really, really nice thing for you, so I didn't have to rewrite this. But let me tell you, this is exactly what you find about when you work with Jamla. Okay. So Jamla is an internationally recognized leader who continuously advocates for enhanced global disaster preparedness. Her work significantly improves emergency care efficiency in resource-limited settings and shapes international response strategies benefiting vulnerable populations. And that's wonderful. With more than 15 years of nursing and disaster response experience, she's made enduring contributions through leadership, innovative training, and advocacy. As a lieutenant commander in the U.S. Public Health Service and a former executive assistant to the Deputy Surgeon General, wow, her impact is recognized with a number of prestigious awards. And you can see them blurred behind her. She's just kind enough to where, she's not going to be overly showy about them, but you can see them back there. I love that. And she's absolutely all of them I know are well deserved. Okay. Her legacy includes extensive disaster preparedness training for healthcare professionals internationally and leading dozens of presentations and exercises. And that's not an easy thing to do. She's a Harvard. She as a Harvard disaster medicine fellowship alumni. Sorry, I screwed that up. I really practiced that multiple times. And currently, a faculty member with the Disaster Medical Fellowship at Harvard. She strengthens nurses' global disaster response roles. She's developed innovative just-in-time training. She has worked in preparing teams for deployment to conflict zones. She's equipped more than 100 responders with critical skills that have been critical when it comes to life-saving. And she also she's a passionate advocate for increased disaster preparedness, funding, and policy, which we can never have enough of out there right now. She ensures that nurses are recognized as essential leaders globally. Very, very important. And as a mentor and a contributor to key publications, she has shaped a more resilient emergency nursing workforce. On top of that, she has some recent accomplishments. She recently got her DNP. Very proud of you. Congratulations on that. And was recently inducted as a fellow in the Academy of Emergency Nursing. So again, the accolades are there, and they're extremely, extremely well deserved. So Jamla, thank you for being here tonight. It's absolutely wonderful to have you.
I am a little uncomfortable now. Wow, where did you get all of that? I'm sitting here looking at these pictures and I was like, wow, some of these impressive. I'm a little
The
speechless.
internet is an amazing thing, isn't it?
I I'm a little speechless. First and foremost, thank you. Thank you for having me. Thank you for having me on Emergency Nurses Day. I'm super excited. I just want to say happy Emergency Nurses Week to all of you. I do want to get a shout out to the emergency nurses for Jen, first of all. Also, I do have some international colleagues here. So I have my friends from Canada. I've got Trent Mosier. I've got my pediatric colleagues. So I've got Pat Frost. I've also got my friends from Japan who are here. So I do want to give a shout out to them. And then, of course, our flight medics, our flight nurses. So Jake Miller. Some of you I have met, but I can't remember because I don't know your faces. But that does not mean that I do not appreciate you all being here. So thank you. If I had more time, I would literally tell you every one of these pictures where they were. And they all meant something. Like, oh, okay. I'm
And
ready,
this
Steve. I
and
am
and
ready
this
to
is just
go.
this is
Oh,
just a distillation of what I was able to find.
oh
So again, it just goes to show you
man.
she's out there and she is doing us proud as and disaster nurses. So again, thank you for that, Jamla.
Representing.
And here's a
Oh,
little
no,
smile for
thank
the day.
you. A chimp. Oh,
Chimp being chased. All right. So let's get into
I laughed. That was funny.
it. So obviously, when I saw this, in I believe it was the July issue, if I'm not mistaken, of
Right,
Jen,
sir.
I was
Correct.
immediately glued to it. I mean, I do love the articles that are in Jen that are obviously a little bit more clinically based or a little bit more career focused, and that's exactly what this was. So the title of Jamla's article is "Disaster Nursing for Early Career Emergency Nurses," and again, as somebody myself who has been involved with disaster preparedness and emergency preparedness over the years, both working at the federal level as well as regional, and then most recently running the emergency management program in the town I live in, this holds a really near and dear spot in my heart. So again, the ability to have you here tonight, Jamla, to talk about your article is greatly appreciated. So I'm going to kind of turn it over to you, and let's kind of tell us a little bit about kind of what your thoughts are behind writing the article, and then educate us as to why we should be looking at a trajectory maybe toward disaster nursing.
Absolutely. Before we do that, actually, if I could just do a shameless plug, only because you talked a little bit, Steve, about how sometimes people kind of shy away from publishing in any journal, but even like our journal, the Journal of Emergency Nursing, yes, we're kind of biased because we love that journal, but sometimes we shy away from it because it's very research heavy. However, for the disaster section, and I'll just, again, I'm biased because that's my section, but that one, and this was in the early career section. They're not researched articles. So these are section papers. They're typically between 3 to 10-ish pages long. Kind of like Steve said, you work with a mentor, you work with the section editors. And I don't want to say we hold your hand because I don't want to sound demeaning, because I don't really think that's the right way to say it, but we really support you in writing about a specific topic. So if any of you on this call, on this line, are uncomfortable or want to publish, but perhaps have that fear of, I can't do research, I don't even know where to begin, please reach out to anybody on this call that is on the board, or even just on the, excuse me, not just on the executive board, but anybody from Jen. Even reach out to Steve and he will put you with the right person, because we really will support you in publishing, even if research isn't your thing. But I digress. Introduction as far as this. One of the things that I am going to put in the chat, I'm going to put it right now, and you'll notice on this slide, there's a little asterisk by the term natural. And I really want to stress how here in the United States, and I don't know in Japan, so Takata, I'll ask you if you don't mind putting it in the chat if you guys use that term, because you guys are very advanced in regard to disaster preparedness, from what I've learned from you guys, but also from my time in Japan, in regard to natural disasters. So textbook definition of what a disaster is, you can see it right there on the screen. But when we talk about disasters, we talk about the man-made disasters, we talk about the ones that cause loss of life, limb, but a natural disaster is something we really want to change what we say. We want to get away from saying natural disaster. And the reason why is because when we think of earthquakes, or we think of wildfires. Those are natural hazards. And so if you click on that link, it'll take you to a post I wrote about it. And the United Nations Disaster Risk Reduction, they say that those are national or natural hazards. What makes it a natural disaster, so to speak, is the way that it impacts communities that are less vulnerable. So, for example, where I live close to water. So, if a disaster such as an earthquake or a hurricane hit my area, I would be very severely impacted. But if I lived in an area where an earthquake or a hurricane happens all the time, it would not necessarily impact me like it would if I lived in a vulnerable community. So, there is that word that we're trying to get away from. So, again, it's going to take a lot of us to kind of go ahead and shift away from that. And there's a great graphic from United Nations Disaster Risk Reduction in that post that I just shared with you guys as well. Perfect. Thanks, Pat. Oh, sorry. Go ahead, Steve.
We're good.
Awesome. So what, and there's incredible information out there in regard to billion-dollar climate events. And then for those of you that have taken TNCC, if you open it up to the disaster section, right, the first page, I think it's actually the second page, but if you've taken TNCC, if you're an instructor, or if you've taken the class, one of the first slides is billion-dollar disasters, and that's billion with a B. And here in the United States, when we talk about disasters, disasters are very sexy, right? And so when we were writing this paper, when my dear friend Sarah Wells, who's one of the section editors for early career nursing, reached out to me and said, you know what, nurses really want to know how to get involved. And I said, well, you know, disasters are really sexy and everybody wants to get involved and do that. But what about the proactive and the public health side of things? And so we were talking about, you know, the billion-dollar side of disasters. And everybody was like, you know, there's a lot of money in regard to disasters. And so this past, oh my gosh, 3 weeks ago, we were in New Orleans. It feels like just last week, but 3 weeks ago, when we were in New Orleans for our ENA conference, I actually gave a presentation on climate events. And one of the things that we stressed was, in a non-political way, was how if we don't go ahead and invest in disaster preparedness as it pertains to climate related events, $1 billion is not going to be enough to support the infrastructure of the damage that's going to be done as a result of disasters in the future. And I'm not even talking, I know this says in the past 20 years it's quadrupled. I would argue in the next 2-3 years, quadrupled, it's going to be even more than that in the next 2 or 3 years from what we're learning right now. Yeah. I mean, in 2020 alone, yeah, over 50 million people. I'm telling you right now, there are so many resources that are telling us that in the next 2 or 3 years, just based off of the disasters that are happening related to weather, our infrastructure is just going to be decimated if we don't go ahead and be proactive. And so we keep thinking that if we, you know, invest in disaster preparedness, which again, I'm totally for, that we'll be able to mitigate a lot of this stuff, but we can only prepare for so much if there's no more earth to prepare for. And that's the biggest problem. We all see our disaster life cycle. This is the emergency management life cycle. Steve is the expert. I mean, he talks about trauma. You've seen this, you know this. But one of the other parts that we don't always emphasize enough is the other gap, which is what if there's more than one disaster happening at the same time? And so in this paper, I'm only talking about a couple of different issues, right? I'm telling you some disasters that I've briefly been a part of. I'm telling you how different hats that I've worn, as Steve and I talked about previously, you may have heard if you kind of jumped on a few minutes earlier, we wear different hats, right? He was part of a DMAT or disaster medical assistance team. I was as well. I was a flight nurse, a flight medic. We've all worn different hats. But the problem with this is that if we have multiple disasters, and I want you guys to think of this as we go through this presentation, if we have multiple disasters and we have multiple players, we have to think about interoperability. How are we all going to play together, work together during this disaster. So think about that as we go through the next few slides. So, a couple of things about me, as Steve so graciously mentioned, made me a little uncomfortable, but thank you. Yes, the internet is a great tool sometimes. So, what is disaster nursing? One of the great things about the internet is that you do have the opportunity to go ahead and network with individuals from all over the world. So, this gentleman here in the top, that is Travis. He is a former he is an Army PA, a physician's assistant. He actually just retired. Him and I actually teach a lot of disaster preparedness. So I teach for him in regard to his global health and wilderness program. And so when we talk about what is disaster nursing, don't be siloed into thinking, well, what can a nurse do teaching PAs? Again, this is where we wear multiple hats, but I am a nurse and I'm so humbled to be able to teach alongside a retired Army PA who used to be the White House, a part of the White House medical team. So again, that's when I said think about the interoperability, we all bring different things to the table. And so when we think about that, my perspective is going to be a little bit different, right? So my focus is going to be on providing care to those individuals. And it's not just, okay, I treated that patient, I'm done. It's, okay, well, what's next? What about when that patient goes home? So if you look at that third bullet, right? What about the family? What about getting medicine? Okay, well, what about when they go home and they don't have this? The things that are constantly running through our minds. Whereas some of our other ancillary providers or other staff members may not think that way. And that picture actually in the bottom, I teach as part of Harvard Disaster Medicine Fellowship, and we do an international pre-deployment course where we have fellows from all over come and we run them through this course of what it would be like to actually provide care if you were going to deploy to a humanitarian disaster, right, or humanitarian environment. And you can obviously see me in the front. And we teach not only physicians, but EMS. How do you miss me, right? And again, this is that opportunity for us to go ahead and say, as a nurse, as a disaster nurse, I can still offer some different perspective to individuals that have different experiences. And that's one thing that I hope you all get out of this is that we are not just nurses. I am fortunate and blessed to be able to be in spaces and be at tables where, as a nurse, I can still sit alongside multidisciplinary people and we can have conversations and I still have something to contribute that they didn't think of. And I'm not saying it's always right, and sometimes I get laughed at, but I'm still welcome at those tables. And that's where we as the nursing profession, sometimes people don't realize that our input is very valuable. So types of disasters. So if you have the paper that Steve sent out, this is in there. This is why I put out in the chat already. This is where I said natural disasters. Again, I'm trying to shift, I'm trying to bring us back to what the international community is. We know that sometimes it takes a really long time to change. When a book is published, sometimes the information is outdated because it takes so long to get something published, for example. So even though in this paper it says natural disasters, you guys are going to go ahead and be that game changer, and you're going to spread the word on why they're natural hazards. And why it's not a natural disaster, or why we call it a natural disaster, is because the community is vulnerable and cannot manage it. And you can also see listed there other types of disasters. And again, if you follow the news, whether it's recent or before, you can easily find any type of those disasters that have happened within the last, I would argue, just past couple of months, last 6 months. You can't even turn on the news any day without hearing something that has happened disaster wise. And let me be clear, I'm not just talking here in the United States. I'm talking internationally as well, unfortunately. And if you guys have any questions in the meantime, you can just drop them in the chat. So feel free to go ahead and just drop them in the chat. You heard me use the term interoperability. So it's not like there is a set of skills that you can just Google and say, hey, ChatGPT, what is the set of skills that I need to be a disaster nurse? Now, there are disaster competencies. Let me be very clear. In fact, there is going to be another webinar for the World Association for Disaster and Emergency Medicine, and I'll put that in the chat. And that is going to be coming up on the 12th of November. And again, if you follow me, like Steve said, which I appreciate the plug, that'll be on all the social media outlooks as well. It is going to be all about international nursing competencies as it pertains to disaster nursing, etc. And so those are just suggested guidelines. And I say that to you because we know that there is not one set of standards between the United States and different countries. So some things that I have seen in practice and that I highly recommend is the fact that you have to be adaptable. And though this is not research, from what I have read and from what I have seen, these are some things that constantly come up. So you have to be adaptable. You have to have some sort of competence, meaning you have to have some sort of foundation, right? You have to be able to have the ability to work in different team settings, interoperability. Again, that's what we do in the ED when we work with EMS, law enforcement. We also work with different agencies sometimes. Sometimes I say working with the different floors is like a challenge in itself. So having that cool, calm, collected mindset of being able to communicate under that stress when you're trying to give report. And then the confidence. I say confidence because I use the analogy of you have to be calm like a duck. So if you are stressed on the outside, everybody's going to notice it. So on the outside, on the surface, you have to be calm, unbothered, but underneath, you can be paddling like crazy on the inside, right? You're moving your legs like crazy underwater. Your heart's beating super fast. That's a normal response. I still to this day get nervous. My heart rate goes up to certain responses. That's okay. But on the outside, just like if you're in a code and the family members are looking at you and you're anxious and you're looking around like this, they're going to notice that something is wrong. So having the confidence to be perfectly poised and present yourself that way, even though sometimes you don't know what's happening, saying that people are not only going to respect you, but that's also going to make sure that people understand that, hey, you're in a calm, cool, collected manner. And that's going to also give you the opportunity to make decisions in a chaotic environment under a cool head, because sometimes it's very hard. Shameless plug. Sorry, Steve. I also did collaborate with somebody else. So, like Steve said, if you go to the website, www.genonline.org, I also did publish with another nurse colleague on mental health of like disaster responders. I published one years ago, but there's a recent one that was just published in Gen. You can't miss it. So if you get the journal, you'll find it. If you don't, you should be. And so that is in the journal as well. And it talks a little bit more about ways to go ahead and kind of work through some of the symptoms of, hey, you're burnt out, or you have PTSD, or you have secondary trauma. And hate is a strong word, so please forgive me. I truly hate when people say that you cannot have PTSD from working in an emergency department, like a level one, for example, from what you constantly see. I think that there is a stigma, and I will be the first to tell you that that stigma is not something that we as emergency nurses should believe in. I think that that is something that we should educate others on. I will be the first to tell you that from all the disasters that I have been a part of, every response that I have been in, for whether it's working in the States or working overseas, I personally get mental health support. I am sharing that. I am being completely vulnerable and sharing that with you all. And I think it is important that we also tell others that it is okay to get mental health support. Otherwise, we will not be able to care for others. We are incredible human beings, and sometimes these things that we see that we are doing we can't even put into words. And so it is going to make us burnt out. It is going to give us that secondary trauma exposure where sometimes we're on edge or we're jumpy. And those are normal responses to that exposure, but that's not normal for us to be that way all the time. And I could sit here and stress this conversation all day. But I just want you all to know that it is okay to seek mental health. It is not showing us that we are inadequate. It is just something that we need to go ahead and understand. Unfortunately, we see and do things like I said. And there is another paper in Gen, if you look at it, that also talks about ways to overcome it. First thing is recognizing it, talking to somebody, seeking out mental health, and understanding that this is sometimes just as a result of what we see and do. So, this is just some of the ways that you can get involved if you are interested. Now, I know not everybody is a new or early career nurse, so I want to start off out of order from this chart, okay? So excuse me if you're following along with this chart. I'm going to kind of go out of order. So if you are an early career nurse, one of the things that I do recommend is get involved with your local EMS. I was an emergency nurse right out of nursing school in New York. Back in the day, that was allowed. I know sometimes there's different rules for different states. But after I went right into the emergency department, I got my EMTB, my basic. And then I also became, I used to ride in an ambulance. And I thought that was a great way to not only build up my EMS skills, but learn also how to better communicate. Because I always saw that there was a communication issue, or it was almost like they were talking in a different language. So if you are an early career nurse, I highly recommend that you get involved with EMS. I think it's a great opportunity. If let's say that that's not your thing, and let's say that you are maybe not an early career nurse, you've got a couple years underneath your belt and you're looking to do something a little bit more advanced. There is the MRC, which is the Medical Reserve Corps. And then there's also the American Red Cross. And then there's FEMA. They are volunteer and sometimes there are paid positions. So it just depends. They do a variety of different things. So let me focus on the Medical Reserve Corps and the American Red Cross first. They have ways for you to volunteer for disasters too. So the American Red Cross and then the Medical Reserve Corps. American Red Cross does a lot with reunification. They usually do set up shelters after a disaster. A lot of times when there is a disaster, and let's say their family members are looking for family members that potentially have been lost or displaced, you'll see on the news that says, if you are looking for your family member, call this number. And that's typically run by the American Red Cross. Highly recommend if you're interested in that kind of support or setting up shelters, American Red Cross, you will learn a lot. Medical Reserve Corps, they do deploy nurses to disasters. I also volunteered with them. This was like 2006, I think, 2008. So that was a long time ago. And they actually do deploy people, even just locally, to do like vaccine clinics. They do countywide exercises. And so that was a great opportunity for me, that interoperability, that word that we were talking about earlier, to kind of see how the different teams played together. Teams meaning EMS, law enforcement, fire department, and then the local emergency departments in regard to the response time. So that's another way to get involved too. They also did some other cool things, like they did rabies clinics. So like I got to do paperwork and like draw up vaccines and interesting things. DMAT, so DMAT is the Disaster Medical Assistance Team. That is a intermittent, so you're an intermittent federal government employee. And so this is something that you have a full-time job. So I did this for about a decade. So I was a full-time nurse in the emergency department. And then when there was a disaster, I had certain months that I was on call. And then when there was a disaster, my nurse manager knew the months that I was on call, and then they would find coverage if I was deployed. And typically the deployments were 2 weeks. Sometimes there were three. Now they're a little bit different. Sometimes they can go up to a month, but that's highly unusual. Typically they're about 2 weeks. The challenge with DMAT is that DMAT is getting restructured. And the problem with DMAT is that you have to apply on USA jobs. It is a federal job. And again, it just takes a really long time to get in. And so sometimes people just kind of give up. But if you do have the opportunity to do it, it is very rewarding. It just takes a long time.
Yeah, and one
Last
thing I'll
but not,
say, one
oh,
thing
sorry, please.
no, go ahead, Jam. I'll finish up when you're done.
No, no, please, because you were a DMATer too. Go ahead.
Yeah, I mean, and I agree with you. I mean, it's very frustrating, and obviously anything in the federal government, it moves at a glacial pace. What I will tell you, and particularly, and I can speak, more expertly here in New Jersey, every municipality in the state of New Jersey by statute has to have an emergency management program in your municipalities, and then that flexes out to having county-based emergency management and goes to the state level. And I will tell you that regardless of where you live in New Jersey, your town has an emergency management coordinator and has an emergency management committee, and they're always looking for some level of expertise outside the typical bounds. And I can tell you, when I was the emergency management director for my town, I couldn't get enough nurses sitting on my committee because of what we bring to the table. So if you want to just dabble, you want to go low impact and low commitment, that would be a really good place to start as well.
And I agree with you. And I think that's one of the things that people don't always take into consideration is because they always want to go big and go with the big names like MRC or
Yep.
DMAT or FEMA, the big names, but sometimes they don't consider my local public health department or my local state department because they do those drills. And like you said, nurses can get involved, but sometimes people don't even know about them. And so I think that's something that we as nurses can be more involved in because we do have a lot to offer, just people don't know about them. One other thing that I did put in is the US Public Health Service. I put that in there as well. So if you are interested in ASPR, which is the Administration for Strategic Preparedness and Response, so I'll just put that in the chat. It's ASPR. That is one agency. There's also the Center for Disease Control. There's Homeland Security, so Department of Homeland Security. These are just agencies that nurses can work for. The, excuse me, those are just a couple of them. But the reason why I'm mentioning those just off the top of my head, because they have the FDA, so the Food and Drug Administration, they have specific programs as it relates to disaster preparedness, and they're all part of the US Public Health Service. So if you have any questions on that, feel free to Google that site or go to that website. There are many other faith-based organizations as well. I do have a colleague who did some research into that. So if you are faith-based and want to get more involved in that, there is a huge organization that's shifting preparedness and response to faith-based organizations because we know that buy-in is a challenge. And we know that if we tap into the faith-based leaders on a local level, we're going to get that buy-in early on. And so then as nurses, it's going to be easier to, respond and evacuate people if needed during that disaster. Go ahead, Steve. And then I'll just say one other thing as you're switching the slide over. And that just has to do with, because I can never forget my PEDS friends, because Pat will I can't say what I want to say, but go ahead. You can turn the slide over though. PEDS, right? So one of the other things is there are specialized teams as well. I know we have a lot of people here from Boston, but Brigham and Women has a specialized team. They have a surgical team that's part of DMAT. They also have, well, they did have there's a disaster mortuary team. So if that's some of the things that you're interested as a nurse, there are teams that literally go out and just help identify victims after disasters. And some of the other things is specifically for pediatrics. I know for myself, when I was down in Puerto Rico during Hurricane Maria, I have a PEDS background, and so I know nobody likes to touch PEDS. Kids are not their thing, and so that was just something else that I had the opportunity to do was just to care for the kids. So just some things to consider as well if you have specialties besides just, oh, I want to be a disaster. There's other avenues as well.
Yeah, and real quick before I change the slide, one other thing that pops into my mind, and I talk about this all the time when we're doing the disaster module for TNCC, is your hospitals have emergency preparedness teams. So at the very, very simplest thing, and maybe even you can conjure getting paid to do this as well, is reach out to whoever your emergency preparedness or emergency management coordinator is for your hospital. Sometimes it's a nurse, a lot of times it's a retired cop or a paramedic or something like that. Like to see more nurses in these roles, but also like to see more nurses getting involved within our own hospitals and doing these types of things. Patricia, go ahead.
Yeah, thank you. I'm Pat Frost. I'm the executive director for the National Pediatric Disaster Coalition. And I thought one of the things that might be of interest to your group is that, ACS basically, for all levels of trauma accreditation now, for every hospital, now has a requirement that each facility participate in a PEDS Ready a program. And what that means is that there's a self-assessment that the hospital needs to complete, and also where there are gaps to ensure that it's included in the trauma quality improvement. So those are the two things that are involved. And PEDS Ready, if you haven't heard about it, invite you to, come to our website. I'll drop it into our chat and the EMS for Children's website to become familiar with that. But it really is the foundation. You need a strong foundation in terms of just basic preparedness for children, just like for basic preparedness for trauma, in order to be ready for a disaster situation where you very well could see, a number of children very rapidly. This happens all the time now. I mean, in every community, we have risks for school shootings. It's
Mhm.
really in everyone's best interest to do everything that they can to have a minimum level of preparedness for children, and that's PEDS Ready.
Absolutely. Thank you for that, Pat. It was certainly a bit of a, we'll call it a bit of a hot topic down at General Assembly this year in New Orleans, trying to get, again,
Yeah.
ENA on board and pass some binding resolutions that would allow for, pediatric care coordinators within the EDs and stuff. So it is a huge thing. It is an area that we definitely need to spend more time in. And I'm certainly glad that ACS got on board and started to really push that, at least for the trauma centers and now across for emergency departments in general. Did you freeze up, Jamla? Uh-oh. Can you guys hear me okay still? Thumbs up if you can. Okay, good. Jamla might have frozen up a little bit here, so let's give her a minute to maybe right size. Great thing about technology is that when it works well.
Sounds like Jamla's having her own disaster.
Yeah, yeah. It definitely looks that way.
Well, we have a moment. Let me chime in my 2 cents because I may not have time at the end.
Sure, Joe.
But um, life experience is probably one of the best teachers for all of us. And I think this has been a great overview and introduction for newer nurses to disaster nursing. Um, but I'm a simple guy, and I try to put things into buckets. And living in the Boston area, you have things, we call them planned disasters, like the Boston Marathon, the 4th of July on the Esplanade. We know we're going to get hundreds of thousands of people, and so you just deploy forward all of your disaster resources to absorb a lot of the patients that they're going to need care, so it doesn't overwhelm the hospitals. So it's a nice way for nurses to get involved. Um, I did have the opportunity to spend a year in Iraq running a combat support hospital where our daily bread was sort of like mini Moscow. So we would get an IED or there'd be a firefight, and you're getting 10 and 12 casualties at a time. So that became in the same kind of continuum, sort of a planned disaster. So you're not going to get onesies and twosies. So you already have at the flick of a switch, you can call up 5 or 6 trauma teams and be ready to go. And then the last one, I think, is what she's sort of covering now, is the one that's not planned. And I think that's the thing that people need to keep in mind is that no disasters are the same. All disasters are different. And you could do all the disaster drills that you want, but nothing follows the script of your drill. So you have to be nimble, you have to stay in the balls of your feet, and you have to be prepared to react. For example, like the Boston Marathon bombing that happened about a decade or so ago, was didn't follow any of the scripts that and even though we had forward deployed, all of the disaster resources to take care of lots of people, didn't follow any of the scripts, but it worked out remarkably well. So no disasters are the same. No drills are going to completely prepare you, but use your life experiences that you've picked up along the way, and I think it holds you in good stead. I see Jamla's back on, so I'll turn it back to her.
Sage advice, Joe. Thank you so much.
Sorry, my computer decided to freeze and restart, so I am on my phone, so please forgive the interruption, everybody, but thank you for filling in. So types of trauma and disaster, there's multiple different types. You can read more about this here, but I just want you to think of just like, for example, let's go back to TNCC, right? There's the acute phase all the way back to, sorry about that, excuse me. There's the initial phase, there's the acute phase, there's all the way up to the tertiary phase. How you are impacted, not just you, but think of your patients as well. So if I am somebody that had, this is my first time experiencing a trauma, I may react differently compared to somebody who has been exposed to repeated types of trauma. So this is why I talked about mental health as far as, the responders. Think of not only your patients, but how myself, as somebody who has responded to multiple types of traumas, disasters, or even just a community that's responded to multiple types of disasters, kind of like the Boston Marathon. They've experienced multiple types of disasters, what have you. They're just going to be impacted differently. They're going to respond differently. Trauma-informed care. So this is something that we try to incorporate in the journal and kind of everything related to disaster nursing. So anything that is in the disaster nursing section of the journal, you'll see that we're trying to incorporate trauma-informed care. And the reason why is because we don't talk about this enough. And Steve, I don't know if you do that in your section, but at least for we trying to incorporate the TIC, trauma-informed care, a lot. And the reason why is because these are things that we need to consider when providing care for our patients. And it's not just, okay, well, we should know this already. Make sure that they're safe. Make sure that we're providing adequate communication. These are not things that we're stressing because, okay, we know we should do this. These are things that during a disaster, we need to be overly concerned about doing. Safety is extremely important. Just because you remove me from the situation doesn't mean that I'm safe. So if you removed me from a disaster, which is right there from my carpeted floor to my non-carpeted floor, doesn't mean that you removed me and now I feel emotionally safe. I can still look over there and see my non-carpeted floor, and I'm still triggered by what I just saw there. I know that's a kind of a silly analogy, but when we talk about safety, it's literally as simple as moving somebody from a completely different environment. And if we can go all the way down to just recognizing trauma, I think that's extremely important. I want to give you guys an example of ironically, a pediatric patient. This is something that happened in New York. There was a pediatric patient. This was shortly after 9/11. And the parents brought the patient into the emergency department, and the patient was in a catatonic state. And as we are all triggered by what we saw when the airplane struck the Twin Towers, you saw that the news kept re-showing the images of the planes hitting the Twin Towers. But as adults, we knew that it wasn't the same thing. It wasn't happening over and over and over again. Cognitively, we understood that it happened once and they were just re-showing it. Well, the parents, as I mentioned, brought their child into the emergency department in this catatonic state because the child thought that this kept happening over and over and over again. And so when we think of things like recognition of trauma, understand that kids process things a little bit different. And again, that's just one example, but some things can be very triggering. The other thing, again, another shameless plug, sorry, Steve, but there is another article in the journal. I feel really uncomfortable talking about all of these publications in Gen. So that's why you guys just need to start publishing. So please reach out. But there is another, you guys just need to start publishing. There was another paper that was just published, myself and an international colleague, actually, in regard to cultural sensitivity. I look like this. It's pretty obvious. I'm very approachable. But I always say to people, tokenism is something that you should not assume. What do I mean by that? Just because I wear this headscarf, for example, doesn't mean that I know everything there is about being a Muslim, right? And so I say this to you because you may think that you have an understanding about a certain group or a certain population, but you may not. And so we still have to respect that patient, that population, by asking that patient specifically, how would I treat you? Or is there something I specifically need to know to take better care of you? And there is a paper that, again, I published with an international colleague about cultural sensitivity and how to really approach patients who maybe are different than us. And that is also published in Gen. And I will not ever miss an opportunity to talk about peer support. And that is also stressing reaching out to your colleagues, getting support, whether it is from a counselor, whether it is from a peer, or seeking out mental health support. So implications for emergency nursing. So for those of you, again, shameless plug, that want to go ahead and publish in the journal, this is something that we require in every paper that is published. So why do I care that a paper is getting published in the emergency nursing journal? Why do I care that, it's going to get published? Well, because we want to make sure, like Steve said in the beginning, that you guys know what you're going to take from this paper and apply it to your everyday practice. So what are you going to take from this disaster nursing paper for early career nursing? Well, as many of you may consider a career in emergency nursing, in disaster nursing, sometimes you are going to be presented with disasters in your emergency departments, whether it is a train derailment in East Palestine, Ohio, whether it is we have the earthquakes and landslides in Cambodia, or our friends in Japan, for example, our friends in Canada. Trent, you guys had, when we were there last year, what did you guys have? That horrible smoke that was coming down from the fires. Again, you may work in an emergency department and then be presented with different types of disasters. So it may behoove you just to go ahead. The forest fires, that's what it was. Thank you. I couldn't remember. But we were feeling that impact just from where we were. And this was way up north compared to where we were. So I hope that the implications for emergency nurses section and this paper that you guys all have, really that you share it with others and you understand that even if you never decide to go into disaster nursing, you do realize that what you do every day has a little bit of a disaster to it, because of the fact that whatever comes through that door could be an MCI. It could be, I don't want to say plane crash because there was just one, but Jake, in your world, for example, responding to disasters, plane crashes, or a PEDS MCI where there's a bus rollover. These are things that you may have to put on your disaster nursing hat, take off your emergency one, and apply some of these skills and some of the lessons that you learned from here. You learned from the geek, the trauma geek, from that as well, and also from our PEDS resources, and also understand that, again, it is okay to get some help if you need it. I highly recommend it. And please reach out if you want to collaborate on any papers, or if there's anything else that you think that is missing from this paper, because there are some things, and maybe we can identify a way to entice others to join next time, or maybe you can present on things that we didn't talk about. happy to address any other questions. And again, I do apologize for the network connectivity issue. Flexibility, adaptability. Didn't we talk about that? That was like lesson 1. Ugh.
Well, I'll tell you, I can to lead off the conclusions from the author. One conclusion that I've come to after reading the article and after listening to you tonight, Jamila, so we're all disaster nurses, whether we want to admit it or not. Okay, the term emergency nurse is such a far-reaching term, right? So as we all sit here today, we are emergency nurses, we are trauma nurses, we are pediatric nurses, we are critical care nurses, we are disaster nurses, we are transport nurses, we are all of that. And I think that's what keeps us all so on the tip of our toes when it comes to what we do, because we do so much and there are so many different things that we do that you just, at the end of the day, we are the jacks of all trade. So you know what? Whether you want to be a disaster nurse or not, we're a disaster nurse, but you can bring out that inner disaster nurse in you by looking at some of the resources, rereading this article, and then reaching out to Nurse Jamila, because she is certainly, if she hasn't proven it tonight, just go out and just Google her, and you definitely will find that this is an individual that you want in your call book, and use her. She is absolutely phenomenal. So
I appreciate
I'm going to give you the last word, Jamila.
Sure. I will say we work a lot in silos, and that is very uncomfortable. So I do have a personal relationship with Pat. So I'm going to name drop Pat, for example. So I do steal a lot of Pat's pediatric stuff. For example, she knows I steal it. I share it, right? But you'll notice that some of the things that I do share, I'll have an adult component, but then there's a pediatric side of things as well. And so, for example, yes. And so you'll notice that a lot of the things that I do, there's a vulnerable community population that I talk about, but then there's a pediatric or an adult component too. So let's stop working in silos and let's please reach out to each other. I am truly humbled. I literally am still a little uncomfortable by all of what you said in the beginning. So thank you for that. But please, let's not work in silos. Please, let's share that information, because at the end of the day, not only do we get a whole week, but we have this day to truly understand how important our role is. And if we don't take opportunities like this to get to know each other and share, like I have this quote that says, my biggest fear in life is looking back and what did I do with it? So I hope you all will share that with me and allow me the opportunity to keep making that impact and make that impact with me. So thank you again, Steve, for the opportunity, and thank you all for joining tonight. And happy Emergency Nurses Day. For
sure. So anyone wants to come on, anyone has a question for Jamila, I mean, this is your opportunity. I mean, you know, you're chatting with the Jamila. So any thoughts you had, any comments you want to have, any experiences you've had. Joe was nice enough to come on and talk a little bit about his experiences. Joe ran one of the major trauma centers in Boston for many, many years. He was in the military, has tremendous military experience. So how about you guys? What, come up and, talk a little bit about what your experiences have been and shed a little bit of light on maybe something a little bit off from what Jamla's talked about.
I love MilCiv coordination. I think that's really important. Somebody mentioned riots earlier. That's extremely important. We have a colleague in Canada. I can't remember where he is in Canada, but riot medicine is extremely, extremely big. What else? Music festivals. What else? Bravo Zulu, man after my own heart. Thank you. What else? Some other things that are really big, if you guys are not focused on this or paying attention, not to scare anybody until people cut me off, because I'm like, Steve, I can talk till I'm blue in the face. CBRNE stuff, chemical, biological, radiological, nuclear, rad tech stuff. That's extremely important. Pat, I think you and I had this conversation. Oh, this was a while ago, or maybe it was another group. I think it was when the war in Ukraine broke out. And this was, again, this is not a political conversation. We're just talking, I think it was the PED side of things where we were concerned about, there's nuclear reactors. And so for those of you that live near nuclear reactors, do you know what that plan is? But I don't live near one, right? So I don't know what happens or what that plan is. So can you guys teach me, or can you share that potentially in a paper? Because I'd love to read about it. But then when the war in Ukraine broke out, we talked about, if we had to evacuate all those kids or even those adults, do we have the capacity so the space, the capability, the skill set, and the interoperability, the teams to work together to bring those people. So I challenge you guys, if you guys had a specific disaster, do you have the capacity, so the space, the capability, the skill set, and the interoperability, the teams? Like, how do you do that? I always use kids because people are afraid of kids, right? But what scared me is like nuclear radiological.
Yeah, and a lot
That's
of people are
scary.
very scared about, radiological. And
Yeah.
actually, there's been some very nice studies done back quite a while ago that basically just with some basic information and
Mhm.
education, it really makes it manageable.
Mhm.
There's very specific things that you can do. And
Absolutely. We just have to share that info.
you just have to have access to the info. I think what's really interesting right now is that, with the new PRISM guidelines, which are the new standard of care is the only standard that has been thoroughly researched in terms of decontamination. That still needs to get off the ground in terms of education and training. And so, it has been published and the research has been published and it's been sitting there for I think over 5 years. I have to go back and take a look at it. But the thing is that this makes things a lot more manageable and it's a much more realistic way to deal with all sorts of decontamination issues as far as that's concerned. And so right now, we're in the practice of doing things a certain way, triage or decontamination and stuff. And then new information becomes available that is really important. We need to change our practice,
Exactly.
like Peds Ready. It takes a really it's a big lift and it takes a really long time for that to get translated from being a journal article to make it part of your day, yeah, really appreciate all the Jamla and I are BFFs as far as that's concerned. Our
Plan
organization
that's better.
our organization is basically, involved in really making this operational as far as that's concerned. And we share shamelessly. She doesn't steal anything.
I bar. We bar.
We
Yeah.
share shamelessly, and we need to practice that as a
Yes.
best practice. That should be the best
That
practice.
should be. I agree.
This is
Yeah.
an older version, but this is what Pat is talking about. But this is an older version, but something like this. And again, if you follow Pat, American Academy of Pediatrics or National Pediatric Disaster Coalition, any of that stuff, or if you follow my blog, any one of those, when something like this, I think actually during September, I did do a CBRNE one, and there's a CBRNE post. I don't know if I did one for peds, but again, I typically will do an adult version and I don't do the pediatric one on the same day. I try to like separate them, but there's things like this with resources. So it's all out there, guys. We share.
Yeah, the problem we have in disasters and really in almost everything in medicine, it's not that the information is out there. We are really have a big problem in getting the information into the hands of people when they need it. And we keep on, repeating over and over again. But one of some of our work and the work that Jamla does is basically getting out there and being a squeaky wheel and just talking about this stuff to anybody who will listen.
I'm on my phone. I'm sorry. It's embarrassing, but
Yeah.
anyway. Okay, stop.
There's just so much stuff and it's just there for the taking. It's open access.
It's all free, guys. It's all
Definitely
free.
take advantage
It's all
of it,
free.
for sure. For sure. All right, so let me flip over to here real quick. I'm going to put in the chat box a link so you don't have to just like get out your phones and try to capture this QR code. This is to do the evaluation. So go to this link on SurveyMonkey, do the evaluation, and give the requisite information, your name and your email address, and just as simple as that. In the next couple of days, I will send you a CE certificate suitable for framing. So you'll get that. And since we're a little bit over the hour mark, we'll go ahead and we're going to mark this up to give you 1.25 hours of credit for tonight. So this will be very helpful to all of you. So again, this is in the chat box. Take a look at that and just click on it very quickly and do the real quick survey. And then again, I'll do my shameless plug is December 17th, 8 p.m. Case of Parkour. All right. I know some of you during this talk have probably been Googling what is parkour, right? So you'll don't Google it too much. All right. Don't want to lose the have a spoiler alert here. So if you are interested, please join me on December 17th. We'll talk a little bit about this goofy little thing, and we'll have a little bit of fun in the process. So with that ado, Jamla, I cannot
I appreciate you.
thank you so much for tonight. This has been absolutely phenomenal. Thank all of you that have stayed with us. This is my contact information should you need to get a hold of me or want anything from me. Again, the Trauma Geek, and we've got Nurse Jamla. So we definitely want to make sure that you guys know that there are resources out there. As Pat said, don't ever be shy of going for these resources. They're out there. They're excellent resources, and they ultimately will shape not only our practice, but the patients we take care of. So thank you all for your time tonight. Greatly appreciated. And again, happy Emergency Nurses Day.
Thanks, guys.
Be safe.
Thanks, everyone.
Thank you. Great topic.
Excellent.
Thanks, everyone. Thanks for joining.
Thanks.